Move on from there. The definition is really pretty simple, and I'm not sure that we do this well all the time. Anybody that wakes up at night with sore legs, cramps, or otherwise, we often, we being providers, just tag them as having restless leg syndrome. Um, but the definition is really simple. It's the symptoms are provoked, that we just talked about, are provoked by immobility, and they're relieved with ambulation or moving. And I'm not sure we always get that part. We go and look at that part, but we should, because it is part of the definition. Obviously, occurs most commonly evening or at night. 1 in 12 adults in the US have symptoms at some point every year, and 3%, like we talked about a minute ago, note distressing symptoms at least twice a week. It is associated with other comorbidities, and you can see the list here. And the slides will be available if anybody wants to get them. But cardiovascular disease, depression, suicide, MS, end-stage renal disease, uh, iron deficiency, anemia, that we'll come back to that in a minute, peripheral neuropathy, and Parkinson disease. So these are the conditions that have pretty strong association with RLS. Other risk factors, family history plays into it. Females about 2 to 1, Northern European descent, and the older you get, the more likely it is to occur. So again, the diagnosis, a clinical history of significant nighttime leg pain, which is relieved by movement or ambulation, and then we get to treatment. So the very first thing to do is to look at iron, and there are really two different things to look at: ferritin levels, ferritin level less than 100, or documented iron deficiency anemia. If you meet either of these two criteria, then you replace iron. And typically it's oral iron every other day, 1 dose every other day, 6 to 8 weeks, and then you recheck levels. There's a rare person that might need parental iron. I don't know if I can go back. All right, I won't go back. But before we leave that, keep in mind ferritin is also an acute phase reactant. So if you check that level at a time when they've got an infection or a significant acute problem, the levels are going to be high. So they may have low levels under normal conditions. The second step in treatment is really, especially in our population, non-pharmacologic. We'd love not to use medications if we can avoid it. So if their iron is fine and they're not iron deficiency, the next step would be to go back to the definition and to see if rapid interventions to ambulate them, get them moving, if that helps or the symptoms to just go away. Because it'd be much nicer to get somebody up, have them walk a few feet, put up with the pain for a minute or two, and then have it go away. And if it only is happening once or twice or 3 times a week, that's a whole lot easier than taking medication every day. When that doesn't work, third step would be to stop medications if you can that increase the risk for RLS. The most likely causative agents are things we use all the time. So SSRIs, SNRIs, and again, this will be part of your psych pharm meeting, but this is one more reason not to use them if you don't have to. And keeping in mind, I get this all the time, please, now's a bad time to stop these meds because a roommate just moved out, or, it's the anniversary of their spouse dying. And those are not reasons really to use antidepressants. They're not going to change that. But here's one more reason to get rid of it if you can. Dopamine antagonists, again, this is going to come up at Psych Pharm, but you can also do this on your own, especially first and second generation antipsychotics. Antiemetics, really, metoclopramide, Reglan, um, can cause it. And then the H1 antihistamines, particularly Benadryl, but Atarax and other medications can do it as well. So any of these things you could discontinue, if possible, would help relieve the symptoms. Um, Final choice would be gabapentinoids. And yes, you heard me say this, even though I'm not their biggest fan generally. But it looks like Neurontin, 1 to 300 milligrams given only at bed, or Lyrica, 50 to 100 milligrams only at bedtime, is an appropriate treatment that works. And how well does it work? Well, in the randomized controlled trials that looked at it, 70% of people had marked improvement with either the Neurontin or the Lyrica at bedtime. And even so, placebo was effective 40% of the time. Uh, the review in JAMA that this came from didn't suggest trying placebo first. But for me, 40% response with placebo is a pretty nice response. I might be tempted to try that first, but who knows? Um, the anti-treatment. So what not to do? And this is really, this next thing is the thing that led to presenting us today at Journal Club. What do you not do? You don't use dopamine agonists. So ropinirole, pramipexole, uh, retigotine, less common. Um, they're not recommended. And the reason for that is that they actually augment, they make RLS symptoms worse over time. The longer you have people on them, the more that the dose goes up. And then they start having symptoms during the day. And you find people taking these drugs 2 or 3 times a day. So this was part of what Dave presented a year ago. The AASM study said don't use them. They actually work for a couple months. They relieve symptoms and patients are happy because their symptoms are gone. But after a couple months is when it starts augmenting the symptoms, making it worse. And then the patients don't want to get rid of them. They hang on to these drugs and don't want you to take them away because they remember how well they worked that first month or two. But this is really the key. Don't if you have patients on them, get them off. Treat them appropriately because eventually you're going to make them worse. All right, here's the reference. This is out of JAMA just a couple weeks ago. And again, if you need this, I've also got the reference available. So any discussion or quite, oh, Dave Bolshoon raised his hand. Dave, talk to us.
Was there any discussion of Suboxone?
Uh, there was an
Okay,
indication for, I mean, yes and no. Um,
let me
late
let
in
me put in a plug
the fine
for
print.
Suboxone. So I have
Yeah,
a neurologist, Dr. Aaron Hogg, who put me onto this, and it is in up to date, and I can give people the
right.
up to date. And he said you start with a 2 milligram Suboxone strip. And for those of you who don't know, Suboxone comes in these melt away strips. And what and that is just way too much for these people. And what you do is you give them a quarter of a strip and it melts away in their mouth. And the amount of opioids that we're giving them is minuscule.
Yeah,
And apparently it has been very helpful. Now, would I recommend going up to the 8 milligram of Suboxone? No, absolutely not. A little bit should work. Maybe 2 squares, maybe 3 squares. But if you need to get up to a 2 milligram of Suboxone dose, then we're not treating the right thing.
yeah. They did talk about in the review eventually getting to opiates. They didn't specifically talk about Suboxone, but I like the idea. How difficult with the strips, because I haven't seen it to actually do it, how difficult is it to cut to a 2 milligram strip?
I have not had anybody. I've got Jimmy he likes taking it 4 times a day. So he takes 4 milligram strips, cuts them in half, and takes and that's for his opioid use disorder. So,
Yeah,
but no, I don't think I have trouble. They're not sticky, I don't think.
yeah. So
They're
we've
not like
got
fruit roll-ups.
yeah, we've got Jen Conley. So Jen from the pharmacy, if
Tell
Dr.
us.
Bullshoot ordered a quarter of the 8 milligram strip, um, how big a deal is that for pharmacy to send it?
Yeah, we wouldn't be able to cut it at the pharmacy. The nurses would have to do it. And so I think in our population of long-term care, it wouldn't be feasible to have the nurses be cutting them, being that it's a controlled substance.
Yeah, because one strip lasts you 4 days.
Yeah,
I guess we could waste 3/4 of a strip. We'd have to be very desperate. I have an
yeah.
N of two, so I don't have a lot of experience.
Well, it's a good plan.
Maybe okay.
We
Thank you,
should,
Jen.
yeah, we should think about that. Any other questions,
I have a
comments?
question.
Yeah.
So, you mean in terms of gabapentinoids? I think the treatment option you gave us, I'm assuming they're the short-acting neurontine. What's the difference? What about the long-acting versus short-acting? And some of them recommend giving long-acting gabapentin around 5 p.m., like 300, 600 to start. Is there any difference between the two?
Well, you you certainly could use it. Um, I would think that you'd want to start with the short acting first. You know, it's the geriatric thing, start low and go slow. If you can get by with 100 milligrams of short acting at bedtime and the symptoms are taken away, you're much better off than using 300 or going to long acting. Um, but if you, but again, even there, if you end up with the long acting, it's safer than using Mirapex or Pinerol, the things that we're used to using. So you're already better off.
Okay, thank you.
Thanks, Sabina. Any other questions, input?
This is
Okay,
a weird,
Yeah.
oh, sorry,
go
Greg.
ahead.
Oh, go ahead.
So I've always heard that, well, and read that restless legs was associated with menopause and perimenopause, but there apparently no type of any kind of hormonal treatment is recommended. Is that correct? I haven't read this article recently in JAMA.
Yeah, it wasn't brought up, but it certainly makes sense, especially it's older is a risk factor and Northern European and women 2 to 1. So, maybe there is validity to that. I'm not sure I've seen any studies that have tried to look at that specifically.
Got it. Thank you.
Close that door when
Sure.
you're way back. I gotta.
Okay. We're just going to move right along then. We'll go to the next
Oh,
topic.
I had.
Oh, Lido, go ahead.
Sorry. Sorry, I was trying to get someone to close the door in here. Background noise. So I have seen a fair amount of RLS emerging specifically in the setting of some low-grade withdrawal from other substances, primarily opiates and or benzos. And I'm
Mhm.
wondering in that scenario, is it better to slow down a taper or even go back up a notch on a less than ideal substance that a patient has already been dependent on, or to try to, try these other adjuvants to deal with the symptoms in other ways?
Yeah, I think that's probably case by case, and I'll take any other wisdom from the group here. But for me, I would probably slow down the taper, but continue to do it, and with an intent to eventually get to the gabapentinoid at bedtime. Any other thoughts on that? Yeah, I just find it I'm not sure I would want to go unless you know, we're trying to hurry and withdraw their benzo or their opiate. And looking back, you think you probably went too fast. That might be a reason to go back up a little, along as long as it comes with the explanation that we're going to slow down how we're doing this, but we're still getting rid of it, or we're still cutting it way back, or whatever the situation may be.
Thanks.
Okay, sure. All right, next, deprescribing proton pump inhibitors. Um, and I'll give you the reference here in a minute, but overuse is common. Um, it's associated with unnecessary spending and modest risk of adverse drug events. And I think that because PPIs are so effective and people that have gastritis really like them, they just don't, it's another drug. They just don't want you taking it away. Um, but if you start looking at the data on the potential risk factor, adverse effects, it gets pretty overwhelming pretty quickly. Um, so this is just a summary of the data that I've collected over the years. Hip fractures, and I just put in, for most of these, I put in the original. There's oftentimes newer references, and you can ask me for these. I'll be glad to send them out if you want them. But hip fractures go up significantly um, the longer you're on them. Bacterial pneumonia, and there were I think John Morley, this was American Journal of Medicine, did an editorial with this, talked about how if you're not on PPIs, most bacteria that make it to your stomach just get killed in the acid milieu. But if you're on PPIs, the bacteria that stay there thrive or don't die. And then if you aspirate them, these are typically sterile aspiration pneumonias, unless you're on a PPI, and then they become bacterial pneumonia. Nutritional deficiencies, magnesium comes to mind, but there are other agents as well. Kidney impairment from JAMA Internal Medicine 2016. C. diff, the first time I saw this noted was in this journal in 2006, but the incidence goes way up. There's the magnesium. The FDA sent a warning letter out to providers in 2011 talking about that. This one is bothersome. Cardiovascular outcomes after an MI are significantly worse for people that were on a PPI. And then B12 levels are lower. Okay. This actually came from a huge Danish study, and I love the Scandinavian studies because the HIPAA just doesn't get in the way. They have these, they're socialized, they have these enormous national databases of health records, and they can just mine these things for studies. This was a study from, I think, about 500 sites, but 34,000 participants that they looked at. The study itself was looking at successful ways or comparing ways to deprescribe PPIs. And I didn't really want to talk about that today, but the ways that they deprescribed PPIs to different degrees worked, education, all kinds of different things. They worked, and it was successful. But part of the follow-up to their study was they took 10% or 3,400 of the participants at random and followed them for the next year to see how they did now that they were off of the PPI. And after the year, comparing them with those that were still on the PPI, there was no clinical difference, clinically meaningful difference between those on the PPI for that next year and those that weren't. And then here's the study. If you're interested, there's a study and an editorial that talks about this. So I think part of this is just the memory of, couldn't eat Mexican food, and now I can eat it. I just take my omeprazole before I go, and life is good. So, any okay, Christine, I
Thanks,
love
Greg.
this raised hand.
Oh, I can't tell you how much I appreciate these journal clubs and the work you put into them. So thank you. So probably
Sure.
TMI, but I have GERD, and now I wonder if I should have been more empathic when I was a younger doctor to people who have GERD, because it's pretty awful. But that said, I think there's some confusion out there. My GI doctor actually told me you don't have to worry about PPIs because those studies that show it shows increased fractures were only in smokers. And I don't think that's true, but I just thought I would ask you because it sounds like there's some confusion out there.
Yeah, it wasn't in the trial that was in JAMA, this original. It was well randomized. It wasn't just smokers. Uh, and there was also pretty good reasoning about why it happened. So it's not just smokers.
Yeah, I just wonder if we're getting GI consults and you hear that, I just thought I would raise that point. Yeah.
Yeah, and I also haven't heard anything about I haven't seen any studies on pulse treatment. So, treat somebody for a month, let them get better and take it away and come back again in 3 or 4 months, treat for a month and sort of pulse on and off over time. I don't know how much that would decrease and maybe these comorbidities that we're seeing. And I'm not sure anybody's doing it or anybody wants to. It wouldn't pay for itself, so I'm not sure it'll get done. Okay, last we're going to end up with, and this comes because I work in a different part of my life, with a whole group of younger people, 18 to 30. And it has impressed me over the past few years how many of them, especially among the women, young women, it's almost a competition to see who's on an SSRI and then who's on two, and some of them on three. And I mean, it's like it's a goal to get on SSRIs because I just feel so much better. This is another one of those Scandinavian things. 4.3 million residents aged 18 to 90. This study was actually I don't know why they just published it this year, but their data was collected from 2010. They looked at deaths from 1999 to 2009, and they separated those deaths into sudden cardiac death or non-sudden cardiac death. That was it. Really simple design with a boatload of people. And don't worry about the actual numbers here. They're just in the next couple slides. They're here just to show you that it was statistically significant data. Antidepressant use was defined as anybody that got more than one prescription in a calendar year. Within that, they separated people into those that took 1 to 5 years of antidepressants versus people that took more than 5 of the 10 years of use. And they further separated it into remote, recent, or current use. So lots of different separations, but you can do that when you got an N of 4.3 million. The results. Over the 10 years, there were 6,002 sudden cardiac deaths among this population. And just about 1/3 of them were antidepressant users. So then they started breaking it up into all those groups that I just talked about. If you'd been on it for 1 to 5 years, what was your risk? Well, it was a risk of 1.4, and that was the confidence interval was 1.31 to 1.51. If you're on it more than 5 years, it jumped to 1.7, almost twice the risk. And I'm going to hurry through these because it's just a bunch of numbers that all, and I'll just put them up here. It all shows the same thing. The more you used it, the more recently you used it, the higher your risk. And then they broke it down by drug class. If you were on an SSRI for 1 to 5 years, about 1.4. If it was on more than 5 years, almost 1.6. Apparently, they still used a lot of tricyclics back then. So again, 1.2 and 1.4. Um, but the bottom line is the longer you're on it, um, and the more recently you're on it, the higher your risk of sudden cardiac death. Um, and again, if you look at the total number, what was it, 6,000 deaths, 43 million people, not a lot, but it is a risk. Anyway, it's another reason to reconsider, and that's actually it. It's another reason to reconsider why do we use so many of these drugs. All right. Um, with that, we're closing in on the, oh, wow, we're at the time. I didn't practice this and it came out that way. Questions, conversation, input?
Dr. Gahm, that SSRI study, it sounds like it was observational. Is that correct?
It was. I mean, that's when, yeah, that's what you get when you get these databases.
Right.
If it had been a couple hundred people, or even 1,000 people, you'd probably question it. But if you're looking at 43 million people over 10 years, it pretty much controls itself for all kinds of uh, outside variables. And they said that in the study too. They said, this doesn't prove it, but it certainly is consistent data across multiple different ways of looking at it, and probably worth looking at. Okay. Any other questions or feedback, thoughts? From the regulatory side, I can tell you that, it doesn't get enforced very often, but one of our requirements in long-term care is to use within the approved FDA approved indications, and most of the PPIs are 4 to 6 weeks, which is really when we should be stopping by regulation. It's when we should be stopping PPIs, and there are a few rare exceptions, esophageal erosions and uh, Mallory-Weiss tears and a few other things. But those make up less than 1% of the people that use PPIs. So it's not just an ongoing excuse. Okay. That's all I've prepared. And I guess if there's no further comments, thanks for joining.
Yeah, thank you, Dr. Gahm.
Get better.
Thank you.
Thank you.
Oh,
Thank you.
yeah. Yeah, whoever asked that question, I'll be glad to stay on for a minute. We can discuss what do you do with Barrett's and DAPT. Probably continue to use it as long as you're on the DAPT. Dave, thanks for your input. Sorry that we don't have a good way to cut those strips, because it sounds like a great idea.
Yeah, I thought it's such a interesting. I looked it up because the trend right now is microdosing. Everything is microdosed.
Yep.
This was another example of microdosing.
Yeah. And saying get better for us quickly.
What about plain buprenorphine tablets, which can be given sublingual? Are those available at the lower doses? Can those should be able to be cut by pharmacy?
Yeah, I'd have to look. I don't think we would be able to cut those either. They might have to waste them if they were able to be cut. But I'm not sure if those are able to be cut.
That's what I was going to ask Chen. I mean, buprenorphine is not very expensive. Are we allowed to waste 3/4 of a strip every time we give it once a day?
Sure, as long as the nursing staff was okay with it. I
You got to
know.
have two people watching the waist, right?
Yeah, with
Yeah.
diversion.
So yeah, so my neurologist is going crazy over this. And I've got 2 out of 2 people saying it's the greatest thing since sliced bread.
It's be interesting to see what comes of it here down the road,
Maybe,
outpatient, and then if we have more backing to do it in our setting.
yeah. Okay. Up to date has the references, so if you need them, let me know, okay?
Yeah, thank you.
Thanks, guys.
Thanks, Dave.
Yeah. Thank you.
I was just looking at GoodRx to find out how much the buprenorphine is. Let's see. Come on, here we go. Wow, $45 for 90 tablets of the 8 milligram tablets. Yeah, that would be really cheap. Okay, thanks everybody. Thanks, Sing.
Yeah, thank you. Great information.